Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exams. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic. Today we're going to be covering axial spondyloarthritis, which falls under the rheumatology section of MRCP. This is part of a wider series on the seronegative spondyloarthropathies that are associated with HLA-B27, and so today is the first in this series. So what is axial spondyloarthritis? AxSpA is a chronic systemic inflammatory disease which usually affects the sacroiliac joints, or SIJs primarily, the spine, and on occasion the peripheral joints such as the knee. Ankylosing spondylitis is a term that you may have come across and is a subset of AxSpA, with sacroiliitis evident on plain X-ray, so a more advanced form of AxSpA. AxSpA tends to affect late adolescents and early adults, with onset after 45 years of age being quite rare. There is a male predominance of approximately 2 to 1. Clinical diagnosis is based on multiple factors including imaging, the presence of back pain as well as stiffness. Radiographic AxSpA involves sacroiliitis being evident on X-ray. Non-radiographic AxSpA means that there is no clear sacroiliitis on the X-ray, but usually they may have inflammation on MRI scanning. This is quite a busy slide, but it just shows you the Assessment of Spondyloarthritis International Society, or ASAS, classification criteria, which just demonstrates the types of clinical features that we're looking for. And this primarily has been developed for patients with back pain for over 3 months and for those aged less than 45 years to try and identify early disease. So in this you can see that sacroiliitis on imaging or the presence of HLA-B27 are the core factors. And then after that, there are several other clinical features that are looked for, which we will discuss in further detail. The key signs and symptoms that we are looking for in a patient with suspected AxSpA are lower back pain, prolonged morning stiffness, which improves with movement, and alternating buttock pain. So it's really important to tease these symptoms out when taking a history. On physical examination, you're likely to see decreased spinal mobility and possibly the evidence of enthesitis, which is inflammation of the tendon insertion points at the bone, uveitis or iritis, so the involvement of the eyes, loss of lordosis with exaggerated kyphosis, and reduced chest expansion in more advanced disease. It is usually more difficult to diagnose this condition in women due to less pronounced features and atypical presentations. AxSpA can affect areas outside the musculoskeletal system, and these can be remembered using the acronym ANCSPOND. So here you can see there is aortic insufficiency in 2 to 6% of patients, neurologic involvement, and this can, for example, involve spinal stenosis due to involvement of the spine in this condition. Ankylosing spondylitis can cause secondary amyloidosis, so can affect the kidneys. Psoriasis may be present, and in a later slide set we will be talking about psoriatic arthritis, but psoriasis can be present in the presence of axial spondyloarthritis, as well as other skin conditions such as erythema nodosum. There may be pulmonary involvement with specifically upper lobe fibrosis and restrictive changes. We've already mentioned uveitis, and this can affect up to 30% of patients. In rare cases, there may be an IgA nephropathy. And finally, there may be the presence of discitis or a spondylodiscitis, and this is known as an Anderson lesion. On physical exam, there are a few other things that you may wish to look for, particularly, for example, if you're in a PACES exam and you feel that the patient may have axial spondyloarthritis. So there's 3 specific exams which one can do. So there's the occiput to wall test or tragus to wall test, and this is where you measure the distance between either the occiput or the tragus and the wall to look for an extension in this. You can look at chest expansion, which usually is abnormal if it's less than 2.5 centimetres and normal if it's 5 or more centimetres. And finally, the modified Sherber test, which detects limitation of forward flexion in the lumbar spine, and this is demonstrated in the image to the right. So as you can see, we're looking at the distance between the lumbosacral junction and 10 centimetres above this. And when the patient is asked to bend over and touch their toes while keeping their legs straight, we're looking for a distance of more than 5 centimetres. If this is less than 5 centimetres, this indicates that there is limited lumbar flexion. Axial spondyloarthritis may be associated with a normal ESR and CRP, and there may be the evidence of an anemia of chronic disease, so a normochromic anemia. ALP may also be mildly elevated. Coming to HLA-B27, this should not be a routine test in back pain and can in fact be present in approximately 6% of the healthy population. But nonetheless, 90% of Caucasian patients with ankylosing spondylitis will have a positive HLA-B27 test, and it is also present in 50 to 80% of non-Caucasian patients with this condition. X-ray imaging looks particularly at the spine and the sacroiliac joints. In the sacroiliac joints, we're looking for irregularity or blurring of the joint margins, as is evident on this picture here. We're looking for sclerosis, joint fusion, as well as some subchondral erosions. Looking at the spine, there is a classic change that we look for called a bamboo spine due to calcification in the anterior and posterior spinal ligaments. There may also be evidence of loss of lumbar lordosis, which we mentioned before, vertebral squaring, and a phenomenon called Romanus lesions, which can otherwise be known as shiny corners, and this is due to erosions at the corners of the vertebral bodies. We may also be able to see enthesitis or calcification of the tendon or ligament insertions on X-ray. There are many different indices and scores that are used in the assessment of axial spondyloarthritis. The most common one used in the UK is the BASDAI score, and this looks at fatigue, spinal pain, joint pain, local tenderness, as well as morning stiffness. And it's important to do this whenever patients are followed up in clinic at each turn, so that we can look and monitor their disease, as well as response to treatment. Other scores include the BAS-V, which is a functional index, the BAS-G, which is a global score, and the patient global score, BAS-ME, which is short for meteorology index, which looks at other aspects of clinical pain and spinal involvement, as well as a pain VAS as well. Coming to management, this is really a multidisciplinary approach, as is the case with all chronic diseases. Physiotherapy and home exercise are really important. Patients should be commenced on an NSAID for 2 to 4 weeks, and if the first one does not work, it's always worth considering switching to an alternative NSAID if it's ineffective. One should be aware of comorbidities, of course, such as asthma or renal dysfunction, for example, with the use of NSAIDs. Sulfasalazine and methotrexate may be helpful, particularly with peripheral symptoms, but they are ineffective for spinal disease. If those measures are unsuccessful, then patients can be trialled on biologics, and really there are 2 main classes that are currently licensed for axial spondyloarthritis, which are the anti-TNF drugs, which are listed here, and you'd usually assess the response after 12 weeks, or secukinumab, which is an IL-17A inhibitor, and the response is assessed after 16 weeks according to NICE guidelines. On assessing response, it's important to look for a 50% reduction in the BASDAI score and a reduction in spinal pain. So now let's try some questions based on what we've learnt. The first question talks about a 40-year-old gentleman who presents with a 6-month history of lower back pain with early morning stiffness lasting for 2 hours. He has no comorbidities or drug allergies, and his renal function is normal. He has a family history of psoriasis in his father and inflammatory bowel disease and arthritis in his grandfather. He is a smoker and works as a civil servant. Examination reveals marked restriction of forward flexion. What is the most appropriate first-line management? So there's quite a lot to tease out from this vignette, and this is quite a classic vignette that you may get in MRCP Part 1 or Part 2. So coming to the first part of the question, we've got a 40-year-old gentleman, so he's under the age of 45, presenting with quite a long history of lower back pain combined with early morning stiffness, lasting for a significant period of time, so 2 hours in the morning. So already we can kind of gauge that we're suspecting axial spondyloarthritis in this gentleman. He has no comorbidities or drug allergies, and this is important to know in case we wish to start him on a non-steroidal anti-inflammatory drug, as well as any other drugs. And it's also helpful to know his renal function in that regard as well. Coming to his family history, you may remember we said that HLA-B27 can be associated with psoriasis, and we haven't talked about inflammatory bowel disease, but there are specific forms of arthritis called enteropathic arthritis, which can be associated with inflammatory bowel disease. So again, we can see a picture, a pattern emerging within the family history as well. The fact that he is a smoker is also important. We know that smoking does lead to worse outcomes in this condition. So part of his management may be to advise him to stop smoking. On his examination, we can see that he's got marked restriction of forward flexion, and it would be important to do a full musculoskeletal examination as well. So looking at the answers, based on everything that we've discussed, the correct answer here is to advise him to stop smoking, refer him to physiotherapy, as we saw in a previous slide, and commence a non-steroidal, so in this case ibuprofen. And it would be important to also start him on a proton pump inhibitor as well, and check for any history of gastritis. The other answers are incorrect. If we just go through all of them, on section A advises the patient to stop smoking, but goes immediately to starting secukinumab. And as far as we know, the patient hasn't actually tried any drugs yet, so we need to start him on some non-steroidals first, provided there are no contraindications. The same holds true for etanercept. Hydroxychloroquine is not classically used for axial spondyloarthritis. And again, answer E is incorrect, because we would wish to start a non-steroidal first before considering an anti-TNF drug such as adalimumab. Coming to question 2, which of the following drugs is not licensed for the treatment of axial spondyloarthritis? So the correct answer here is rituximab. Golimumab is a TNF blocker, secukinumab is the IL-17A inhibitor, and etanercept and certolizumab are also anti-TNF drugs. Rituximab is a CD20 inhibitor and is not licensed for the use of axial spondyloarthritis. And finally, which of the following may present as an extraskeletal manifestation of AXSpA? So the options are mitral stenosis, lower lobe fibrosis, scleritis, aortic insufficiency, or eczema. The correct answer here is aortic insufficiency. You don't classically see mitral stenosis associated with AXSpA. In terms of lung fibrosis, it tends to affect the upper lobes rather than the lower lobes. In terms of eye involvement, it tends to be a uveitis or iritis and not scleritis. And in terms of skin involvement, we would not normally associate eczema with axSpA, but we do see psoriasis and occasionally erythema nodosum as well. So thanks for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in the future, and we look forward to seeing you for our next episode.